All right, let's jump right in. Today, we're talking about a skill that is absolutely fundamental for anyone in medicine: delivering inhaled medication. Seriously, if you're treating respiratory diseases, you have to know this stuff inside and out. So, whether you're on the wards or in a clinic, this is your guide. Let's get to it.
So, what's the big idea behind inhaled therapy? It's actually brilliantly simple. Think about it. Why send a drug on a grand tour of the entire body when you can send it straight to the source of the problem, the lungs? It's all about getting the most bang for your buck, right where it counts, with as little friendly fire as possible.
And that direct route gives us some huge advantages. First, you're putting the medication right where it needs to work, which often means it starts working faster. Second, because less of the drug gets absorbed into your bloodstream, you get less systemic availability. And that means, you guessed it, fewer of those pesky side effects. It's just a smarter, more targeted way to treat.
So, how do we actually do this? Well, we're going to break down the four main types of devices you'll see all the time. You've got your pressurized metered dose inhalers, dry powder inhalers, soft mist inhalers, and, of course, nebulizers. Think of these as the essential tools you've got to have in your clinical toolkit.
Okay, this table really lays it all out, the pros and cons of each. Your PMDI, super portable, super common, but the patient has to have perfect timing. The DPI gets rid of that timing problem, it's breath activated, but now the patient has to be able to breathe in hard enough. And the nebulizer, that's your go-to when the patient can't do either of those things, but it's clunky and takes way more time. You can see there's a trade-off with every single one. Let's start with the classic, the one you'll see everywhere, the pressurized metered dose inhaler, or PMDI. This is the absolute workhorse of inhaled therapy. But its greatest strength, its simplicity, is also directly tied to its biggest hurdle for patients: getting that hand-breath coordination just right. And this sequence right here is where everything can go wrong. The patient starts breathing in slowly, and then at the perfect moment, they have to press the canister. That's step 2, the moment of truth. If they press too early or too late, that medicine just splats against the back of their throat instead of going into the lungs. And poof, the treatment is basically useless. This is hands down the most common reason these inhalers fail. So how do we fix this? Well, the solution is a total game changer: a spacer or a valved holding chamber. It's basically a plastic tube that attaches to the inhaler. It creates a little holding area for the medicine cloud, slowing it all down. This completely separates the press from the breathe, so the timing doesn't have to be perfect anymore. It makes a massive difference in how much medicine actually gets where it needs to go. Okay, so what if we could just get rid of that coordination problem entirely? Well, that's exactly the idea behind our next tool, the dry powder inhaler, or DPI. With a DPI, the patient's own breath provides all the power. Their effort is literally the engine. So how does that work? It's all about a cool physics principle called turbulent energy. The patient takes a really strong, deep breath through the device. That powerful rush of air creates turbulence, which is just enough force to break the tiny drug particles away from their bigger carrier molecules. It turns the powder into a fine mist that can be inhaled deep into the lungs. And this brings us to the million-dollar question you have to ask every single time you consider a DPI. Can my patient actually breathe in hard enough? A young child, or maybe an older adult, or someone in the middle of a really bad asthma attack, they might not have the strength. And if they can't generate that flow, the drug just sits there in the device. All right, here are a few pro tips, some clinical pearls you just have to remember for DPIs. First, humidity is the enemy. It makes the powder clump up, so tell your patients to store it somewhere dry. Second, and this is a big one, tell them to never, ever exhale into the device. That moisture can ruin the rest of the doses. You always teach them, breathe out fully, away from your mouth, then put the device to your lips and take that big, fast breath in. Okay, so what if your patient can't coordinate for a PMDI? And they don't have the lung power for a DPI? What's left in the toolkit? This is where nebulizers shine. Think of them as the heavy-duty option, perfect for acute situations in the ER or for patients at the extremes of age or in really severe distress. You're going to see two main types. The jet nebulizer is the traditional one. It uses compressed air to blast liquid medicine into a mist. It's that loud machine you probably picture. But then there are the newer mesh nebulizers. They use a tiny vibrating mesh to create the aerosol. They are way more efficient, super quiet, and often small enough to be portable. And here's a practical number you should just burn into your brain for those jet nebulizers: 6 to 8 liters per minute. That's the sweet spot for the driving gas flow. If you go too low, you won't make a good aerosol. Too high, and you can actually mess up the particle size. So remember, 6 to 8.
Now, when you get to the ICU, the rules change. This chart is so important. Look at DPIs. They're a total non-starter on a ventilator. The humidity in the circuit makes the powder clump, so they're completely useless. Jet nebulizers work, they're okay. But look at the data. The gold standard, believe it or not, is a PMDI with a specialized spacer. It delivers the dose most effectively and reliably in this critical setting.
Okay, we've gone through all the tools in the toolkit. Now for the most important part, the art of medicine, right? How do you actually choose the right tool for the job? Well, it all comes down to a perfect match between the device, the drug, your patient, and the situation you're in. This table is basically your clinical cheat sheet. It's fantastic. If a patient is having a severe asthma attack, they're not going to have the strength for a DPI, so you reach for a nebulizer. Got a patient with a trach? You'll need a nebulizer or a PMDI with a special adapter. And then you have some drugs, like certain pulmonary vasodilators, that can only be given with one specific type of nebulizer. The clinical context is everything. So, after all of this tech and all of the science, what's the one thing you absolutely have to take away? It's this. When they're used correctly, all these devices are pretty much equally effective. So the single most important factor is the person holding it. The best device in the world is useless if your patient can't or won't use it the right way. It always comes back to the patient. And I'll leave you with a little glimpse of what's next. We are heading into the era of smart inhalers. These things have sensors built right in to track when a patient uses them and, more importantly, how they use them. That data can be sent right to us, the clinicians. This opens up a whole new world of remote monitoring and truly personalized care. It's a really exciting time to be in respiratory medicine.